Good morning, everyone. Thank you for still being here. It's my pleasure to announce the second keynote lecture, which will be a debate with two estimated speakers. The first to speak will be Mikkael Sekeres, followed by Eric Solari, and they will debate on the new classification and the two ICC versus WHO.
Now, Dr. Solari and I have pitched this as not so much a debate, but a wrestling match. And we've chosen two wrestlers to represent each of us. The first, you may notice on the right, is André René Roussimoff, also known as André the Giant. He was born on May 19th, 1946 in Coulommiers, Seine-et-Marne. On the left, you will see Terry Jean Bollea, also known as Hulk Hogan, representing the United States, who was born on August 11th, 1953 in Augusta, Georgia. So at the end, you will have to determine who has won the wrestling match. Was it Andre the Giant or Hulk Hogan? So in all actuality, this was an incredibly collaborative effort between me and Dr. Solari. Naming a disease category well can be tricky. In the WHO, we have the myelodysplastic neoplasms, and in the ICC, the myelodysplastic syndromes. Now, I'd love to take a quick poll of the audience. Please raise your hand, those who prefer myelodysplastic neoplasms. Okay, and those who prefer myelodysplastic syndromes. Dr. Solari, I think the ICC has won this one. Myelodysplastic syndromes is still more popular. Now, the WHO, of course, identifies MDS with increased blasts 2, and the ICC an MDS AML category. I'm going to ask the audience for a poll again. Who prefers MDS with increased blast 2? Raise your hand. And who prefers MDS AML overlap? Ooh, it appears this time the WHO has been victorious. It's interesting how old habits die hard. Counting blast cells themselves can be tricky, and this is a display of how, as you increase the number of cells counted, your accuracy improves, meaning the median may remain the same, but the variability in determination of blasts becomes much more narrow. Now, another way of thinking about this is a study we did through the NHLBI MDS Natural History Study. In this observational study that we're conducting in the United States, we're enrolling patients at a suspected MDS diagnosis. So a patient presents to his or her doctor. The doctor says, gee, you may have myelodysplastic syndromes. We're going to do a bone marrow biopsy. It's at that point before the first biopsy that patients are enrolled to this study. A local pathologist makes a diagnosis, and then the bone marrow samples go to expert central pathologists to make the diagnosis. And in this particular study that's been submitted and is in revision at a journal, we looked at differences between the diagnosis locally and centrally, not subtle differences. For example, did one pathologist think it was 14% ring sideroblast and another pathologist thought it was 16% ring sideroblast, but differences in diagnosis between MDS and AML or MDS and vitamin deficiency. And we found that there were differences in those diagnoses 27% of the time between local and central pathologists. So as we debate these nuances between these classification systems, I always try to keep in mind the fact that not every pathologist is going to make the same read on a bone marrow, regardless of how precise we try to be in our classifications. Now, in the ICC, we have refractory cytopenia of childhood, and in the WHO, childhood MDS with low blasts. There also are new entities that have emerged. These include clonal hematopoiesis of indeterminate potential, where there are no cytopenias, low levels or no dysplasia, but mutations that are present at a VAF of 2% or greater. We also have ICIS, cytopenia of undetermined significance, where cytopenias are present, dysplasia may or may not be present, and there aren't any mutations associated with it. Clonal cytopenia of undetermined significance, where there are cytopenias, there may or may not be dysplasia, and mutations are once again present. And then, of course, MDS, myelodysplastic neoplasms or syndromes, depending on whether you raised your hand, that do have cytopenias, dysplasia, and almost all the time mutations that are present. Both classification systems recognize pre-malignant clonal cytopenias, including CCUS. The ICC also recognizes VEXAS, an autoimmune condition typified by a UBA1 mutation and no MDS-defining genetic abnormalities, while the WHO recognizes CHIP. Both the WHO and ICC expand the role of genetic abnormalities in defining diseases. The WHO includes MDS with low blasts and an isolated deletion 5q, MDS with low blasts and an SF3B1 mutation, and MDS with biallelic TP53 mutations. The ICC also recognizes MDS with deletion 5q, MDS with a mutated SF3B1, and MDS with a mutated TP53, but with the requirement that it be multi-hit or have a variant allelic frequency of 10% or greater. There's also MDS AML overlap category in the ICC with any somatic TP53 mutation with a VAF of 10% or greater. But we have to ask, is there a devil in the details? And I do think Hulk Hogan looks resplendent in this outfit. So there's MDS with 5q, where there doesn't appear to be major discrepancies between the ICC and the WHO. This requires deletion 5q with up to one additional abnormality, except for chromosome 7 abnormalities. I would also add to that, except with a TP53 mutation, as this would shift the classification, although it's not as clear in the WHO as in the ICC. There's MDS SF3B1. The WHO excludes chromosome 7 abnormalities, deletion 5q, and complex karyotype. ICC also excludes 3q26 abnormalities and requires that the SF3B1 mutation have a VAF of 10% or greater. And for TP53, the WHO requires that this be multi-hit with 2 or more mutations or 1 mutation and loss of heterozygosity in the other. The ICC requires that this be multi-hit or have a TP53 mutation with a VAF greater than 10% and a complex karyotype, often with loss of 17p. Other MDS entities remain morphologically defined. So for low blast percentage MDS in the ICC, we have MDS without dysplasia, MDS with single lineage dysplasia, MDS with multi-lineage dysplasia. I think, ironically, the ICC is more similar to WHO4 than WHO5 in this respect. The WHO includes MDS that's hypoplastic or MDS with low blasts. For higher blast percentage, the ICC includes MDS with blasts that are in excess from 5 to 9% in the bone marrow, or the MDS AML overlap. The WHO retains the IB1 and IB2 designations and now includes an MDS with fibrosis that can have excess blasts. This was a collaboration among a number of centers around the world that was actually presented at ASH this past year that does show some discriminatory ability in the WHO and ICC among these different categories, but not absolute discriminatory capacity, as some of these subgroups will overlap. You can imagine that the best survival curves are those that include SF3B1, single lineage dysplasia, 5q minus, etc. Of course, the worst curves are those that have increasingly excess blasts and TP53. Some entities are difficult to recognize within both systems. MDS NOS without dysplasia that can be compared to single lineage dysplasia, or in the WHO, hypoplastic MDS versus aplastic anemia. There's also MDS with an NPM1 mutation, which is defined as AML, whatever the VAF in the WHO, or requires a VAF greater than 10% in the ICC. And then there are specific subgroups in the WHO, MDS with fibrosis, in the ICC, MDS AML overlaps with MDS type mutations, MDS cytogenetics, NOS, or in children, MDS with 10 to 19% blasts in the bone marrow. I'm going to hand this over now to my colleague, Dr. Sekeres, to take over.
Thank you, Mikkael. So we move to MDS-MPN, and again, there are many similarities between the WHO and the ICC. Both have kept CMML as it with some changes in the definitions. They both are speaking about MDS-MPN with SF3B1 mutations and thrombocytosis. And there are some discrepancies on the name of atypical CML in the ICC or MDS-MPN with neutrophilia in the WHO. And there is an additional category of MDS-MPN not otherwise specified. In both cases, JMML have been excluded from this category. They moved to the MPN category in the WHO classifications and joined the category of pediatric disorders in the ICC. So regarding this disease, there are, again, many similarities, except the changes in some names and the specific entities on which I'm going to discuss. What the ICC added to that is a category of CICUS with monocytosis and also a clonal monocytosis of undetermined significance. So we will have to learn whether this makes sense in clinics. And also this category of MDS-MPN with ring sideroblast not otherwise specified, that is including, according to the WHO, in the MDS-MPN with SF3B1 mutation and thrombocytosis, if you don't have access to checking the SF3B1 mutation. And finally, again, you have the migration of GMML either to myeloproliferative neoplasms or to pediatric disorders. ICC, this is unique to ICC, has proposed a provisional category of disease, which is MDS-MPN with ISO 17Q, which is defined by an increase in the white blood cell count over 13 giga per liter, cytopenia as defined for MDS, dysgranulopoiesis, ISO 17Q, and one possible other abnormality, excluding -7 and del -Q. Again, like all other MDS-MPN, you have to exclude acute leukemia, CML, MPN, myeloid and lymphoid neoplasms with eosinophilia and tyrosine kinase fusion genes, and previous cytotoxic or growth factor therapy. So there are very few, actually, details in which confusion is possible. ICC is mentioning ASXL1 mutations in addition to ZBP1 and RAS mutations, so it doesn't change a lot. Again, the ICC also indicated that a VAF of SF3B1 mutation over 10% was needed, which is for MDS-MPN with SF3B1 mutation and thrombocytosis, which is not mentioned in the WHO. And the ICC also exclude more cytogenetic abnormalities in this category. Regarding the chronic myelomonocytic leukemia, we discussed it 2 days ago. Again, the monocytosis is similarly defined at a new level. So monocytosis must be both absolute and relative, and the relative is really important here. Clonality markers and cell dysplasia were already present, and the abnormal partitions of monocyte subsets join the two classifications. There are just a few more details in the ICC classification. The subtypes are exactly the same. We have still the proliferative and dysplastic subtypes, the low blast count and high blast count, and it's exactly the same in the ICC. Regarding the MDS that appears after cytotoxic therapy or in the context of germline predispositions, again, the subclassification is very similar in both the WHO and the ICC. These two categories are recognized with different names, but at the end, they are more or less the same. Just, I take the opportunity to remind you that to recognize the MDS with germline predisposition, you have to eliminate the baseline changes in bone marrow cells that overlap with dysplastic features. This is mentioned in both WHO and ICC classifications. You require new and progressive cytopenias with often rising cellularity. You require an overt multilineage dysplasia. You require an increased number of blasts and an acquired pathogenic genetic alteration that can be of different types. When you go to the germline predispositions, you can see here, and I will not go into the details, but they are totally similar in the two classifications, more or less the same abnormalities as mentioned. In addition to that, the ICC also added a series of predispositions that are not really classified, but that are there, mentioned as a germline predisposition to MDS. So there is now a long list of potential predispositions, some of them being very rare. We have also this acute myeloid leukemia myelodysplasia related. Again, the comparison between the two classifications indicates that they are really close. There are only a little bit more abnormality mentioned in the ICC classifications. And finally, I will go through the pediatric MDS. In the ICC, the name refractory cytopenia of childhood was conserved, but the definition is more or less close to that of the WHO, in which the name childhood MDS with low blast was preferred to avoid, especially in cancer centers, the confusions with renal cell carcinoma, I guess. The WHO also described two subtypes of childhood MDS with low blast, one of them being the hypocellular subtypes, but you can see that the ICC is mentioning that in this 80% of cases you have hypocellularity. Inconstant cytogenetic findings are also mentioned in both cases. Nevertheless, there is something to clarify. The ICC include germline predisposition in this category and just mention it in addition to the ICC name, which is not the case of the WHO that exclude different factors that can be responsible for cell dysplasia, including the germline pathogenic variant. So here there is a small discrepancy between the two classifications. Then we move to the pediatric MDS with excess of blast, and here again we have great similarities between the two classifications. So this is where we are. As you can see, discrepancies between the two classifications remain limited. And so what we want to tell you together is that in the interest of patients, we suggest rapid merging of these two proposals.
Thank you very much. So before you move to the mic for the question, maybe my question is in link with your conclusion, actually. Yesterday afternoon, Julien Mancini explained to us that there is a strong correlation between a low health literacy by the patient and psychological distress, which is itself associated with a poor quality of life. And so it is clear that if the patients have difficulties to understand even the name of the disease, then they are in big trouble. So I think that your conclusion is very important because it's also in the interest of the patient that we may have to simplify. And my question is, do you envisage to discuss this point precisely with the patient when elaborating the next classification? One idea that we could not push and finalize, but which I think should be for the next meeting, was to have a session dedicated to the patient perspective regarding the names of the disease and some concepts that are quite complicated, like, you know, the ICUS, CICUS, etc., where you are not sick, but you have something which has a name of a complicated disease. So what's your point of view regarding this?
No, it's a great question and one that's obviously incredibly important to patients. I think there's a variable level of sophistication that patients will have about the diagnosis of myelodysplastic syndromes. And I think one of my first hurdles in talking to a patient about this is raising the specter of cancer. We did a study years ago where we asked patients how MDS was first described to them, and 74% of patients said it was first described to them as a blood disorder or a bone marrow disorder. The word cancer or leukemia was ever raised only 6 or 7% of the time. So I start by actually using the word cancer and trying to put that in context, if it's a lower risk versus a higher risk MDS. When we get into some of the nuances of morphologic distinctions or, whether it's MDS with fibrosis or not, I think that's a very sophisticated patient who will pay attention to that and want to know that. I think more commonly what we're going to have to face is the MDS AML overlap category, where for the first time a patient is going to hear the word leukemia. And as one of my friends once said to me, leukemia needs a better press agent. So most patients have heard of the word leukemia and they know it's bad, and we're going to have to navigate that with the discrepancies between the two systems.
Norbert, could I make a comment rather than a question? As a hematopathologist working in a university hospital with 6 colleagues, 15 leukemia specialists, you could imagine that this has been a very major problem for us. And the way we have solved it to date is we use the WHO 23 as a template, as our primary diagnostic tool. It is readily available on the website. It is easy to use. There is a modest cost, renewable once a year, and it has the ICD coding, whereas the ICC is a standalone publication that you have to turn to on the website every time you want to clarify a particular question. So what we do is, where there is a difference, we make a note saying ICC classification suggests this, but the primary sign-out in our institution will be the WHO 23. As far as what Mikkael has said, the clinicians have a totally different problem. Our problem is the accuracy of a diagnosis. Your problem is to interpret what we say and convert that into low risk, intermediate risk, high risk, and I still feel that the International Prognostic Scoring System, M, is a very helpful tool for patients and their families, in contrast to either one of these classifications. Thank you.
Great points.
Yeah, Jason Chang from University of Chicago. Actually, I expressed my disagreements about the WHO classification, especially on GML at US CAP meeting. So, but I don't want to blame too much about that. But for me, I don't think it's appropriate to classify GML into myeloproliferative neoplasm. That's, in my opinion, GML, it definitely have both myeloproliferative and myelodysplastic features. For example, GML, you commonly see the -7 cases. If you move it into the myeloproliferative neoplasm, we have to subtract those cases, -7 cases. Where do you put those -7 cases with monocytosis? And also, for Pete's case, in my experience, they're always much subtle in terms of granulocytic dysplasia. All the patients you commonly see hypogranulation, but the kids are usually harder to see. And kids most commonly see the small mega or hypolobated megakaryocyte. There's a couple of differences. So personally, I don't think we classify this GML into myeloproliferative neoplasm is appropriate move. I think this category should be separate. I like it. ICC classification, move it into the separated pediatric categories. So that's my first, I want to discuss with panel and discuss my opinions on this. So I would like to hear what you guys think about it as well.
Thank you for raising this point. Of course, as you can imagine, we had a lot of discussion on that. Nevertheless, what we think is that one of the unifying features of GMML is the hypersensitivity of progenitor to a cytokine, which is GM-CSF, which is more or less the definitions of all the myeloproliferative neoplasms. And based on these pathogenic insight, we decided to move it, and it was said today that GMML is more or less a RASopathy. It's very specifically disease due to hypersensitivity of progenitors to cytokines. So this is why we move it to MPN at the end. So is it an issue for the patients and the way they are considered and treated? I am not sure. I think there is some dysplasia, but the dysplastic component is not as important as in MDS MPN of adults. That's what we know.
Yeah, I think they do make a bigger difference because in terms of treatment, because if you move this into the MPN myeloproliferative neoplasm, and those patients will not get, at least what I was told, not get it as azacitidine treatment for this patient. And as azacitidine treatment, in my experience, in my case, deal with at the University of Chicago, some patients respond very well. So this has a consequence, not just diagnosis consequence. People say, yes, this is like a RAS promoting proliferation. Its future, I agree with that. But if you look at like other, like FLT3 acute myeloid leukemia, MP1 myeloid leukemia, also those cases also RAS activated in the pathway drive blast proliferation. You are not going to classify this case as a myeloproliferative neoplasm, are you? So that's I think you need a little bit more discussion before moving this into the myeloproliferative neoplasm. I don't want some people still behind me, so I don't want to take all your opportunity. So,
He's not dangerous.
I'm afraid you can kick me from back. Okay. Anyway, another thing I want to also, I mentioned the last time, WHO brought up this hypoplastic. This I remember many years ago when Dr. Waldman was leading the classifications. This was brought up at that time because there's no data supported hypoplastic really has prognostic impact versus hypocellular bone marrow. So this was not integrated into MDS classifications as new identities. Still today, I have not seen any data. Maybe you guys know more than I do. I still have not seen any data on this hypoplastic versus hypocellular bone marrow in terms its impact on prognosis. I don't know if you have that kind of data to support that.
So, you know, the question that you're asking really gets at a more fundamental question, and that is, what is the purpose of a pathologic classification system?
Yes.
Is the purpose to distinguish among prognostic subgroups, or is the purpose to get to the pathobiology leading to the clinical and pathologic manifestations of the disease that we're seeing? And one of the challenges, I think, with both of these systems is they kind of mix up those goals a little bit, right?
Yeah.
So we see some definitions that are more focused on prognostic differentiation and some that are more mechanistic. So if your focus of a pathologic system is prognosis, then you're right. I don't think there should be a distinction for hypoplastic MDS. If you're thinking about it more mechanistically and potentially therapeutically, then there should be.
That's a good point, actually. I would agree with you at that because hypoplastic, you try to have more autoimmune-related cases. That's a suggestion. I mean, this was brought up many years ago. I just want to make sure what on you guys' mind is what is really in there. I do have last question.
Very last, because we have only 1 minute left.
So one question is, I like ICC, in my opinion, better than WHO. And even because WHO was actually come from Chicago, so I should have loved them. But anyway, ICC, there's categories, MDS without dysplasia. What kind of cases are you guys talking about in that category?
Not sure I am able to answer these questions. This was mentioned as one of the difficulties of this classification. This specific entity will be probably very difficult to answer, to recognize. In
my opinion, very frankly, I don't think that should be there. It just says MDS. I mean, we know MDS characterized by the two features. One is ineffective hematopoiesis leading to pancytopenia, preferred cytopenia. Another feature is myelodysplasia, which is due to apparent differentiation caused dysplasia. But
if we succeed in working on merging these two classifications, these are probably these kind of details that have to be discussed again, for sure.
Yeah, but
okay, thank you. So we will take the very last question, if you don't mind.
Okay.
Niklas? And then we will have to move to the next session.
Thank you. First of all, thank you for this nice presentation to give us at least an overview of what the difference is. I will give you just a comment, maybe a question, not from an MDS expert in the field, so just from a general hematologist. And I'm a bit concerned that you are losing ground control, yeah? Because we are talking about a disease which is, let's say, is in general a rare disease, yeah? Where therapeutic options are limited, and we are in a field which is rapidly evolving, molecular genetics, and this will be not the last classification in the next 5 years. There will be another one, I'm sure, and you are only concerning the community. So I'm working in a hospital in a high-income country, and I still see patients without cytogenetic in MDS. And you propose things here which nobody is understanding. Yeah? Nobody in the community, in hematology, is really following you. And that I'm really concerned that you are losing control because you are a rare disease. And if you want to convince caregivers, if you want to convince funding agency, yeah? If you come up with so complicated issues and the academic society is not clear, is not speaking in one language, I'm concerned that you will get funding on other things. So you should really try to make it simplified as a simply score or simply modified for the community. And this is more helpful because this is confusing everybody in hematology. Even if you are interested in MDS, this is confusing. This is my comment on this. So thanks.
Amen, brother. I mean, we agree.
I'm sorry, in following what Nick said, Moshe Mittelman, Tel Aviv, I absolutely agree. I think our community has to remember that here, people who are interested in MDS are sitting. Classification has to be simple, clear, and should be distributed in many parts of the world. In many parts of the world, they cannot do NGS, they cannot do cytogenetics. It doesn't mean that we do not have to make advance and to say what is proposed or what is suggested, but we have to make it clear and simple. Right now, we are confused, okay? There are two new classifications. In a way, there is some kind of overlapping between the IPSSM, and as Nick says, maybe we'll have more. I think my suggestion to the community is to get together and to try to do another one, simple, which will be adopted by hundreds of people, and this will become the classification of the world for the next few years. Otherwise, we are still in a mess. That's my message.
Thank you very much. And we are seeing that the debate is still open, so you may continue and stay for a few more days here in Marseille, if you like. So thank you very much to both of you. Now I'm calling my co-chair, my next co-chair, who is Professor Bennett. For the last session, which is dedicated to the Tito Bastianello and MDS Foundation Young Investigators Awards.